Hi everyone, welcome to my channel Mod Med Ed, where I go through high-yield medical school content. This video is on PCOS, or Polycystic Ovarian Syndrome. First, we're going to start with a clinical scenario. A 27-year-old woman presents to your office with difficulty getting pregnant. She has been trying with her husband for the past year with no success. Past medical history is significant for irregular periods since menarche and significant weight gain. BMI is 37. Patient also has a history of acne and facial hair. So to start talking about PCOS, I figured we had to start with the follicle. So the follicle has two different types of cells, the theca cells and the granulosa cells. The theca cells produce androgens, and they're stimulated by LH, and these androgens are then shunted over to granulosa cells, which contain the enzyme aromatase, and those produce estrogen via stimulation from FSH. So just adding in the HPA axis for completeness, the hypothalamus will release GnRH, which acts on the anterior pituitary to release FSH and LH. And again, LH is going to act on theca cells, and FSH acts on granulosa cells. So on PCOS, there is an unusually high amount of LH, which is going to act on theca cells to produce high amounts of androgens. Now, these androgens are going to exert negative feedback on the HPA axis, so they're going to inhibit GnRH release and inhibit FSH and LH release. So without FSH release, the granulosa cells are unable to produce estrogen, so you're just having this really high level of androgens and really high levels of LH. So PCOS can cause anovulation and can also be associated with infertility. As we talked about in PCOS, there's really high levels of LH and low FSH. FSH is responsible for the development of mature follicles. As you can see in the image on the right, this is the menstrual cycle, which I'm not going to go through in detail, but just for you to see, the follicle development occurs throughout the follicular phase of the menstrual cycle, and FSH is responsible for that development. So if you have a low FSH, you're going to have no mature development of a follicle, which means no follicle is going to be released, so no ovulation and no menses. This can also lead to infertility, because if you're not ovulating, then you're not going to be able to get pregnant. For the diagnosis of PCOS, there requires 2 out of 3 of the criteria. So the first is amenorrhea, which we just talked about. The second is signs of hyperandrogenism, which would be increased facial hair, increased acne. And then the third is enlarged follicles or cysts seen on ultrasound, which is shown in the image. There's some high-yield associations to be aware of with PCOS. The first is type 2 diabetes. There's a hypothesis that this rise in LH could be due to really high levels of insulin or insulin resistance, and patients with PCOS are more likely to develop type 2 diabetes. There's also an association with endometrial cancer. The enzyme aromatase is also present in adipose tissue, so it'll be converting those high levels of androgens to estrogen. So patients with PCOS are known to be overweight, which means they have more adipose tissue, which means they'll be producing more estrogen, and this estrogen that's unopposed could lead to endometrial cancer. So circling back to the clinical scenario, a 27-year-old woman that presents to your office with difficulty getting pregnant. She has a history of irregular periods and significant weight gain. She also has a history of acne and facial hair. So this is really your classic type of PCOS that you'll see in your in-class exams and on board exams. So just make sure you're familiar with this and understand the pathophys behind it. And that's all for PCOS. Thanks for watching.